Hello, good evening and welcome to live classroom PLAB-1 hosted by Xlink by yours and only Dr. George. We are still in central nervous system. Trying to locate where we stopped the last time. I think it might have been a while. Let's try to go over some of the things that we've gone over before. Maybe kind of pick up where we stopped. Dr. Tara, can you hear me now? Because it seems you are not hearing me before. So I've started live streaming and I've started sharing my screen. I believe you guys can see my screen, right? Can see my screen. All right. No problem. So the question here, I think we've answered this question anyway, but let's still drop it. Question here is about a young man who develops non-fluent, effortful speech with dysphagia. All right, he's able to understand speech, so he's able to comprehend, but cannot. So it's kind of a motor speech deficit, which is also known as what? Expressive aphasia. So he fails to repeat the sentence. What would you do next? I've answered this question before, but again, is it a skull X-ray? Is it a non-contrast CT scan of the brain? Is it contrast CT brain? Contrast MRI? The optic nerves, 4 vessels, cerebral angiography, single vessel angiogram, MRI of the frontal lobe, MRI of the pituitary lobe, MRI of the temporal lobe. So which part of the brain should be involved in expression, motor of the speech? The person can comprehend speech, so the sensory part of the speech is intact, but the motor aspect of speech is affected. So which part of the brain should be involved? Let me see whether you guys have totally forgotten everything that we discussed before. I'm waiting for your answers. You have less than 26 minutes to go. Let's be fast. I'm waiting your answer. Cerebral frontal lobe. Which one is cerebral frontal lobe? Is that in the option? You choose. Scroll down. You can see them now. Welcome, Dr. OS should be Samuel. You're welcome. Samuel was the only one that was checking up on me. You guys didn't check up on me. Clap for yourselves. All right. So which of the options should I check? Should I answer? From MRI of the frontal lobe. All right. Okay, this is the question that had the wrong option marked. This is the wrong option. This is the right answer. MRI frontal lobe is the right answer. All right. Even from the explanation, we know it is MRI frontal lobe. It's a Broca's aphasia or dysphagia. So lesions are located in the prefrontal areas. The non-fluent or expressive aphasia, since there is deficit in speech production, prosody, and syntactic comprehension. Patients will typically exhibit slow and halting speech, but with good semantic content. Comprehension is usually good, and patients will obey commands like usual. Unlike Wernicke's aphasia, Broca's patients are aware of their language difficulties. So Wernicke's aphasia will not be aware of their language difficulties. Prosody is the study of the meter of verse. Here it means the rhythm of speech, right? So sensory aphasia lesions are located in the left posterior perisylvian region, and primary symptoms are general, just temporal region anyway. All this language, left posterior perisylvian region. You know, there's a sylvian fissure, right? So left posterior perisylvian region, and primary symptoms are general comprehension deficit, word retrieval. So this person is finding it difficult to retrieve words. That's person that cannot comprehend. He or she doesn't understand you, doesn't comprehend your speech, and cannot even retrieve words, cannot obey commands because doesn't understand, obviously. Semantic paraphasias, all right? Lesions in this area damage the semantic content of language while leaving the language production function intact. The consequence is a fluent or receptive aphasia in which speech is fluent but lacking in content, all right? So this person will just be talking, but there's no content, all right? Person has the motor aspect, obviously, but the person is not responding to what you are saying. It's just like this thing that happens in when it goes across encephalopathy, all right? Where this person he's just talking. The person has this memory loss, so the person will now be confabulating, like just making up stuff, just be talking, but the person is still confused, doesn't understand you, all right? So that's how to assess that. The next question here is about a 55-year-old chronic alcoholic with known hepatic cirrhosis. Answer this question. Let's I think we've answered this one too. Maybe let's try. An 84-year-old woman with Alzheimer's dementia has recently become incontinent and more confused than usual. What is the single most likely diagnosis? Okay, wrong options. Wrong option. This is the correct one. The trousseau of activity, neuropathic bladder, nocturnal enuresis, UTI, uterine prolapse. It has Alzheimer's, all right, dementia, but recently became incontinent and more confused than usual. Recently, so it's an acute onset stuff. So is it the trousseau of activity, neuropathic bladder, nocturnal enuresis, UTI, uterine prolapse? Which of the answer? I think we chose UTI. We've answered this question before. UTI is only acute stuff here. Dr. Sam, I'm not seeing your input. Can you hear me, Samuel? That 8-year-old man with long-standing alcohol dependence has vertigo and a tremor every single morning. What is the single most likely diagnosis? Anxiety, okay, long-standing alcohol dependence has vertigo, all right, and a tremor every single morning. Tremor every single morning and vertigo. Anxiety, BPV, cerebral degeneration, optic neuritis, temporal lobe epilepsy. Okay, cerebral degeneration, why is it every morning? That's the question you ask yourself. Why is it every morning? Cerebral degeneration, shouldn't it be constant all the time? Or you are linking it with the alcohol? Someone will defend your answer. Yeah, that's why it's every morning. But because of the no, don't change your answer. I say you should defend your answer. You now changed your answer. You can see that they are wrong. Because of the chronic alcohol abuse that leads to temporary or permanent cerebral damage. All right, so long-standing alcohol dependence. All right, that's the factor. So when you now see the vertigo in a long-standing alcohol dependence, you know alcohol can cause cerebral lesions. A 3-year-old woman has had 3 episodes of slurred speech and 2 episodes of transient weakness of both legs in the past 5 years. Each episode has resolved in 3 months. What's this? 3 minutes. Okay. What is the single most likely diagnosis? The 3-year-old has had 3 episodes of slurred speech, like stroke, right? And 2 episodes of TIAs in the past 5 years. That's too many, right? So each episode has resolved within 3 minutes. What is the single most likely diagnosis? So it's a CVA. So what type? Meningioma, migraine, multiple sclerosis, stroke, TIA. So what it is? Is that 3 months or 3 minutes? I hope it is 3 months. Like from the answer you get, like multiple sclerosis. Okay. Transient weakness of both legs. Okay. No, yeah. Because see, when I'm bringing out points, I want you to question your answer, like to think about it. Yeah. It's not because of the multiple episodes that makes it TIA. All I'm trying to is for you to understand what exactly you're answering. So it says 2 episodes of transient weakness of both legs. So this is a paraparasis, right? So it is not a hemiparesis, it's a paraparasis. Transient weakness of both legs. So like, yeah, TIA would have been a hemiparesis, but this is a paraparasis, apart from the speech deficits. All right. So this resolved in 3 months. Let me assume it is 3 months. Because if it is 3 minutes, anything that lasts less than 24 hours is a TIA. All right. So I think this is 3 months. All right. So if person has had multiple episodes of this kind of stuff, it's most likely a demyelinating disease. All right. So multiple sclerosis is the commonest demyelinating disease. And I think in one of the videos we even went as far as looked at what MS involves. All right. The commonest demyelinating disease. Essentially, the Schwann cells, the myelin sheet that covers the nerve cells that help to increase the speed of conduction are damaged. All right, that's the meaning of demyelination. So there's no more myelin cover. Schwann cells are dead, or are dying, or are being destroyed by autoimmunity, right? So there's no more myelination. So the nerve conduction, the speed of nerve conduction is now very slow. All right. So eventually, impulses are generated but are not being conducted appropriately to where they belong. So that's when you now start having weakness, like present with multiple symptoms: blindness, weakness of the body, slurring of speech. So, and multiple sclerosis tend to have different types. There's a type that is just continuous, all right, rapidly progressing, or over the years, all right, progressively getting worse over the years. Then there's this relapsing and reliving type. So this one is likely the one that comes and goes, comes and goes, comes and goes. Relapsing and remitting, relapsing and remitting. All right. So that's multiple sclerosis. 60-year-old boy has been noticed to have problems with coordinating his voluntary movements over the last 2 years. He has a waddling gait and needs to support himself on his hands when rising from the floor. He has larger calves than other boys, but he runs more slowly, which is the most likely diagnosis. Myotonia, myasthenia gravis, Duchenne muscular dystrophy, muscular atrophy. What do you think is the answer? The 6-year-old boy, all right? He has problem with coordinating his voluntary movements for 2 years, which means it's a chronic stuff. He's 6 years, something that has happened. That means it started when he was 4 years old. He has waddling gait. This waddling gait is classical or something known as proximal myopathy, right? Waddling gait, and he needs to support himself on his hands when rising from the floor. That's also a feature of proximal myopathy. So this patient cannot raise their hands up, like doing activities like combing the hair, all right, or picking something from the top of a shelf. They can't do that. Or sitting up or standing up from a sitting position, all right, they can't do that. So it's most likely Duchenne muscular dystrophy. What type of genetic disease is DMD? It's autosomal recessive, autosomal dominant, X-linked. What is it? Let me see those who are connecting the dots. All right. The child is having difficulty with walking, running, jumping, and climbing stairs. Walking may look different with a waddling type of walk, waddling gait. All right. And I think I showed you guys a video of what a waddling gait looks like. The boy may be late in starting to walk, although many children without him also, yeah. When you pick up the child, you may feel as if he slips through your hands due to looseness of the muscles around the shoulder. The calf muscles may look bulky, although they are not strong. As he gets older, the child may use his hands to help him get up, looking as if he's climbing up his legs. This is called Gowa's sign. Yeah. It's Xlink recessive. Well, most times you don't have to put the recessive, but putting it is still good. That's like very specific. But because I think there are only like 1 or 2 X-linked dominant traits. So most X-linked diseases by default are recessive because they are X-linked, because they are shared with the S chromosome. All right. A 45-year-old man presents with a mass on the right side of the face. Okay, let me even ask a question. How many of you have finished this guy's book? This guy's the handouts I put in the Samson and so on and so forth, Unity, all those things. How many of you have read through it, at least the aspect of neurology? Because you have to be studying as well. You know, these are MCQ questions. They prepare you for the exam. They give you an idea of what has been asked in the past, all that. But of course, you will not expect them to ask you the exact same question. They may be similar, they may be related. You understand? Most likely they will be related. They will be similar. They will change options. They will rephrase the question and all that. But I think also picking some facts helps you too. You know, not just answering the questions. You have to have some facts. And the easiest way to pick up some facts is from the works that have already been done, which I put all the materials, because that book is very, very heavy. That's like 2-3 gigabytes of materials. That's what I put for you guys. So if you know what's good for you, be opening it. All right, be studying it. All this while, I expected maybe you guys would have cleared that whole aspect. Maybe you would have finished neurology, finished CVS, finished these all those ones that we've talked about. You should have read it on something. All right, because it's like bullet points, but it's straight to the point for what you actually need for your exam. All right. So please study, apart from the MCQs, you need to use that as like foundation. Even though I'm trying to cover your knowledge gap with what I'm doing here, because obviously what I'm doing here also covers your knowledge gap by bringing in the facts as well. But I think on your own too, you also need your own personal study. All right. So 45-year-old man presents with a mass on the right side of the face. The mass was first observed 3 months ago, but has recently become visibly larger. Right? He feels pain over the mass and is unable to blow a whistle. Clinical examination shows that the mass is likely to be a parotid gland. Why? An oral examination shows a foul-smelling discharge from the duct of the gland, and gentle probing shows that it is stenosed at the meatus. Which of the following features suggests that the mass might be malignant? Presence of pain, recent enlargement, facial nerve palsy, stenosed ductal meatus. Therefore, this mass is growing really, really fast. Like in 3 months, it has become visibly larger on the right side of the face. So, um, presence of pain, well, that doesn't really, pain alone will not tell you whether something is malignant. Recent enlargement, facial nerve palsy, unable to blow away. Yeah, that's like nervous involvement. But could that be mass effect? Because the facial nerve courses through the parotid gland at some point, and its exits towards the face, it courses through the parotid gland, courses through the internal ear. It has a very long, in fact, it's the nerve that has the longest course in the brain, outside the brain, right? So be a mass effect and facial nerve palsy compression, right? Be a mass effect. Then someone said recent enlargement. What do you think, Samuel? So that we'll go with the one with the most popular opinion. The inability to blow. Yeah, yeah, you're making sense. Mass effect of benign tumor can as well cause facial nerve palsy. Yes. Who said, Sarah, are you changing your answer? You said inability to blow. So inability to blow, is that, what's that? Okay, so 2 for recent enlargement. Facial nerve palsy. Who chose facial nerve palsy? Shara. Okay. I get what you're saying. Okay, that inability to blow. As the air escapes while trying to blow, that suggests facial nerve palsy. All right. So it's due to malignant infiltration of the nerve. Not exactly the mass effect, because it's something that started 3 months ago that had already started affecting the nerve, all right, implies that it's super actively growing. And it's not like it present with a mass on the right side of the face. Mass was first observed 2 months ago and has recently become visibly larger. I think that one is also a factor. Recent enlargement, visual nerve palsy. All right, this is the one we just answered. A 50-year-old man with a known history of stroke is unable to get out of his house because he can't find where the door is. He refuses help from his wife and says he is not blind, but single most likely defect. He has past history of stroke. That's the most important of this question. He cannot find the door. All right. He refuses help from his wife because he feels he's not blind, but evidence is the contrary because he cannot get out of the house because he can't find where the door is. But yet he feels he's not blind and still refuses help from the wife. What kind of blindness do you think this is? Paracentral scotoma, tunnel vision, total blindness, central scotoma, cortical blindness. Yes, it is cortical blindness. All right. So the eye will appear totally normal, right? And patient can actually perceive impulses. The retina is working, all right? So patient can actually perceive impulses, visual impulses, all right? Sensation of vision. But when it gets to the visual cortex, which is at the occipital lobe, right? What's that area again? What is it called? Areas, blah, 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 numbers. What's the number for that visual cortex area? So when the impulses get to the visual cortex, they are no longer able to interpret the impulses. Try me 42 again. It's like, I think 21, 22, 23. What type of cerebral artery injury will cause visual cortex? Like which type of cerebral artery in circle of Willis will Broadman area 17, 18, 19. Thank you. Yeah, I used to use it to sing that year. 17, 18, 19, ball. There's a song about it. So it's Broadman area 17, 18, 19. Okay. So let me even quickly look at the Broadman areas again. 3D representation of Broadman areas. See how pretty this thing. This is your brain, Noya. Look at your brain. Very fine. Colored. So this is how smart people's brain look like. All right. So Broadman area is a region of cerebral cortex in the human or other primates defined by its cytoarchitecture or histological structure and organization of cells. Basically, it's like arranging cells in parts of the brain and associating with functions. All right. So Broadman areas 1, 2, 3 is primary somatosensory. This is the lateral aspect of the brain. This is the medial aspect. All right. Cytotectonic map. So let me start with 1, 2, 3 is primary somatosensory. So sensory impulses go to 1, 2, 3 like this. The one painted blue. Then primary motor cortex is area 4. Okay. So where's the prefrontal gyrus? I think it's somewhere here, somewhere around here, right? So primary sensory here, followed by the primary motor cortex, which is area 4. Then Broca's area, which is the area that's involved with motor function of the speech, which is somewhere on the lower aspect of the frontal lobe. All right, Broca's area 44 and 45. You can see Broca's area, right? Then Wernicke's area is area 39 and 40. See, Wernicke's area is somewhere in the temporal lobe. So I think the Sylvian fissure they were talking about is somewhere here. So on the lower aspect of the temporal lobe, you find the Wernicke's area, which caters for the sensory aspect of speech, with area 39 and 40. Right, 44, 45 is Broca's, 940 is Wernicke's. And visual cortex is area 17, 18, 19, right? And you can see visual cortex at the occipital lobe. Okay. Then primary auditory cortex, somewhere on the lower aspect of the temporal lobe. That's area 22. So those are the common areas that we have. All right. The German anatomy is Kobinian, Brodmann. All right, is the one that's by this Brodmann areas, right? So it's not the major thing, but I just got something. When you're learning one thing, it's good to learn every other thing too that relates to it. So the 17, 18, 19, so that's the cortical blindness. Going back to the question. There's something they mentioned there, explanation. So rarely a patient with acquired cortical blindness may have little or no insight that they have lost vision, phenomenon known as Anton-Babinski syndrome. Anton-Babinski syndrome, right? 76-year-old woman presents with deep stroke 6 hours ago. What would be the immediate treatment? They didn't say the type of stroke. They said aspirin 75, aspirin 300, streptokinase, IV heparin, dipyridamole. Well, because patient is 76-year-old, what type of stroke do you think patient will likely have? Should likely be an ischemic stroke. All right. Likely be an ischemic stroke. So, judging by that, and it's within 6 hours. I think we've talked about our number of hours, something. Yes, probably. Kinase, right? Because the patient just had the stroke. So what's the cutoff time? What's the cutoff time? There's a cutoff time. 4 hours. Is it 4 hours or 2 hours? Yeah, there's a very short cutoff time. That's after which giving a antifibrinolytic will no longer work. Sorry, a fibrinolytic agent will no longer work. So I think after 6 hours of stroke, just be like waste of time. Okay. So just give secondary prevention of stroke. That's what they call it: aspirin, atorvastatin, vitamin E, Astocovir, selenium. All those ones are secondary prevention of stroke. The patient has already had the stroke, and apparently there's nothing you can do. Again, you only just prevent further stroke from happening in the future. But if you call this patient within 2 hours of stroke, as well, go ahead and give IV streptokinase immediately, and hopefully it will resolve the stroke. All right. So, as 4-year-old female presented with vomiting preceded by an occipital headache of acute onset. Examination shows patient is conscious and alert with photophobia, but no neck stiffness. CT scan is normal. What is the most appropriate for that management? This is the last question for today. Just warming up. If we're able to start early tomorrow, then we should be fine. 34-year-old female presented with vomiting preceded by an hospital headache of acute onset. The examination, patient is conscious and alert with photophobia, but no neck stiffness. CT scan is normal. What is the most appropriate for that management? What is the diagnosis? What do you think is the diagnosis? Yeah, it's likely an SAH. Cerebral angiography may be more useful than CT scan. Nuya said it's posterior fossa. So everybody's saying MRI brain, but someone will think it's cerebral angiography. Fine, cerebral angiography will actually show you the SAH. But if you do an ordinary CT scan in SAH, it may be normal though. So except you do a CT brain with contrast, that's when you may find something. You're supposed to use contrast. But in this case, when you have already done CT, it's normal. So what's the most appropriate further management? Further, if you want to go further, right? You know, CSF exam can also give away SAH. What will you find on CSF exam? But they're asking for further. I think CSF exam would have been, but patient is vomiting, so he likely has raised intracranial pressure anyway. So you are not going to go and do lumbar puncture. But what if you were to do lumbar puncture? What would you have found? Blood in CSF. Eh? Which one is blood in CSF? So if I do a traumatic tap, won't I see blood in CSF? Xanthochromic CSF. That's the word. They answer question like primary school. Even primary school will know that there will be blood in CSF. That's so now. Even my nursery one puppy will know that there will be blood in CSF. My grandmother herself, market woman that is here, she knows there will be blood in CSF. It will shock you, say she know. So, wahala dey, they chose CSF exam. I don't agree because patient is vomiting. All right, so she will not know the source of. She will know. It will shock you, say she know. You don't see them come to the hospital. They will make the diagnosis for you. Tell you, patient has partial stroke. They will tell you. But it's when you now use the medical terms, we know that you know more than her. SF exam, I don't agree with it though. I'm going to say cerebral and geography for that exam. The patient is vomiting, which is like suggests raised intracranial pressure. And when you do a tap, when the patient has raised intracranial pressure, well, what happens? Oh, cone, right? Coming or coning. Wahala dey o. Sure. Anyway, any questions, guys? No problem. Patient will come. No problem. According to both Noya and Tara. So tomorrow we'll continue from where we stopped. We've answered all these questions before, but you know, for continuity's sake, let's just start. So we stopped at 16%. All right, 16%. So you guys should remember to remind me tomorrow. Good night, guys. We'll end the live stream at this point.